Our first speaker this morning is Dr. Patrick Brown. He's going to talk about acute and chronic myelogenous leukemia. Dr. Brown is an associate professor of oncology and pediatrics and the director of the Pediatric Leukemia Program at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University School of Medicine. He is the vice chair for relapse and an executive steering committee member of the ALL committee and an executive steering committee member of the Myeloid Committee in the Children's Oncology Group. He co-chairs the National Comprehensive Cancer Network's clinical guidelines panels for both adult and pediatric ALL, and his research focuses on developing molecularly targeted therapies for high-risk childhood leukemias. Fun fact, he recently surprised his extended in-law family on a beach vacation with an Amazon Prime delivery of a 9-person inflatable unicorn raft. Photos available on request.
Thanks, Paul. It's a true story. And my marriage survived it, so that's good. All right, so nothing says good morning like myeloid malignancies, I say. So let's get right into it. So you've seen this slide. We're going to follow this structure from the ABP. We're going to do this in 2 parts. The first part, we'll go through all 4 of these for AML. Second part, we'll go through all 4 of them for CML. All right, so the kind of Bible for hematopoietic malignancies is the WHO 4th edition. And these are the different diagnoses in the myeloid category and as they're laid out in that document. This was recently updated in 2016 with some minor changes, but this is the basic structure of how things are diagnosed and classified. And so I'll be covering CML and AML. You're going to hear next from Dr. McLean about the remainder of things on here, including the myelodysplastic syndromes and myeloproliferative disorders. All right, so let's jump into AML. We'll start with the basic science and pathophysiology. All right, so I'm going to start with, I want to mention that in the old board content outline, it was much more specific in terms of topics they wanted you to focus on. The new makes more sense kind of conceptually, but there's much fewer specifics in terms of what specific items they might want to focus on. So I've left the old, more content-specific things in this talk, and they're in green boxes, all right? And so those are not in the current content outline, but they're in the old one, and this ship is going to take a while to turn around. So the things that they used to focus on content-wise are still going to be in the questions for years to come. And so I think it's important that you know what the old board content line focused on, because there are some favorite themes that they love to test on. And this is probably their most favorite, which is cytogenetic abnormalities in AML. So anyway, every time you see a green box, that's left over from the old content guidelines, but I think will give you clues as to what to focus on. All right, so in terms of recurrent cytogenetic lesions, there were 4 different items that they highlighted, and that's correlating the clinical characteristics with the chromosomal abnormalities, understanding the significance of one specific chromosomal abnormality that I'll go into, which is the 15-17 translocation, to recognize specific clinical syndromes associated with specific lesions, and then to know the molecular abnormalities with which specific and recurring chromosomal abnormalities are associated in AML. So 4 different points, all focusing on the same basic thing, tells you the test makers think that's important. So let's talk about that. This is perhaps the most important slide for you to know, and this I call it the Big 4. So these are the Big 4 recurrent cytogenetic abnormalities that are important for test makers to focus on. And so the first is the 821 translocation. It fuses RUNX1 with RUNX1T1. It used to be called AML1-ETO. You'll hear that a lot. It's associated with a specific morphology, FAB morphology. We'll talk about that in a moment, called M2. And then there's some characteristics. These are the leukemias that most prominently have Auer rods. This is the leukemia that's most likely to be associated with solid chloroma masses as part of the AML presentation. And this is one of the 2 core binding factor leukemias, the 821 and the inversion 16, which is the 3rd one down, that have good prognosis generally in AML. The next on the list is the 15-17. So this is the PML-RAR alpha fusion protein. This is pathognomonic, and there's a 1-to-1 correlation between this and the M3 morphology, which is promyelocytic leukemia. Lots of granules and hour rods in these leukemias as well. They tend to have a high incidence of DIC and bleeding. That's really important to know clinically. And these also now have a good prognosis with the introduction of ATRA and arsenic, and we'll talk more about that later. Next is in version 16. This is the other of the two so-called core binding factor leukemias. It fuses CBF beta with the myosin H11, the heavy myosin chain. There's a very strong correlation between this leukemia and the M4-EO morphology. That's myelomonocytic with eosinophilia morphology. And so there's lots of eosinophils with abnormal basophilic granules in the marrow. These can also form chloromas, and as I mentioned, good prognosis. And then finally, abnormalities in 11q23. These are MLL or KMT2A gene rearrangements. MLL and KMT2A are two different names for the same gene. There are 70 to 80 different fusion partners with MLL, but they all behave basically the same. They have a tendency to be myelomonocytic or monocytic in morphology. There's a strong predisposition in the infant age group for these abnormalities. These leukemias, like other monocytic leukemias, tend to infiltrate things like the skin, the CNS, gums, and also tend to present with high white counts. And this is also the abnormality, and we'll talk about this on a later slide, that is associated with treatment-related AML after etoposide and other topo-2 inhibitors. So we'll come back to these throughout the talk because of their importance. All right, so let's talk about APL, acute promyelocytic leukemia caused by the 1517 translocation, PML-RAR alpha. So this is the normal differentiation shown right now of the neutrophils from myeloblasts. In PML-RAR alpha leukemia, when this fusion protein is acquired by a myeloid precursor, a number of things happen. So first of all, there's production of an abnormal retinoic acid receptor protein. This represses the normal retinoic acid receptor target genes that blocks the cell that has the lesion in differentiation at the promyelocytic stage, as shown here, and that causes the disease of APL. So what ATRA does at a molecular level is it overcomes this block. It basically increases the concentration of normal retinoic acid receptor signaling, and that overcomes the block and allows normal differentiation and subsequent apoptosis. And that's why ATRA is so effective for this disease. So this is a really simple concept, but one that's very important to understand and is tested heavily. Okay, the next thing, know which constitutional and genetic conditions predispose to the development of leukemia. I'm going to keep these comments to the main things that have been in the textbooks for years and that are likely to be on the test. I will briefly mention just a couple of recent discoveries that are really important in this area, but I won't focus on those in this talk. Okay, so what are the major leukemia predispositions? There are a number of bone marrow failure syndromes. Zora Rogers is going to give a whole talk on these later, and so I'm not going to go into any significant detail here, but a number of these will predispose patients to the early development of MDS and subsequent AML. The next, JMML-related conditions. Again, I'm not going to go into these details because this is going to be covered by Dr. McLean next. Down syndrome, an extremely important genetic constitutional predisposition to leukemia. Dr. Lowe did a wonderful job covering Down syndrome and its relationship to ALL. And again, Dr. McLean will discuss its relationship to myeloproliferative disorders and AML in the next talk. And then finally, there's some others. These are conditions where leukemia or lymphoma can be part of the presentation, but there's much broader symptoms as well, things like ataxia-telangiectasia, Bloom syndrome, Li-Fraumeni syndrome. Okay, one more comment. So, traditionally, it's been thought that pediatric AML, de novo AML, is very unlikely to arise from any sort of known constitutional genetic predisposition. That is changing. There's an increasing recognition now that we're doing a lot more sequencing that there are a number of germline abnormalities that likely do predispose to the development of what we would normally consider de novo AML. So think about that, take that back home. You may already be working up more patients for genetic predispositions. This is not likely to be tested on the next set of rounds, but I think I would be remiss not to mention that this is a rapidly expanding field in the era of next-generation sequencing. Okay, so for the bone marrow failure syndromes, again, I'm not going to go into detail because Dr. Rogers will cover it later, but it's important for me to think about bone marrow failure syndromes in terms of how they typically present, which cell line is typically down. So there's a couple of them that typically present with pancytopenia, and those are Fanconi anemia and DKC. There are those that typically present specifically with anemia, like Diamond-Blackfan anemia. There are those that present most commonly with neutropenia, like Shwachman-Diamond syndrome and severe congenital neutropenia. And then finally, there are those that present primarily with thrombocytopenia, like congenital amegakaryocytic thrombocytopenia and familial platelet disorder with predisposition to AML. This last one I want to mention that in the keeping with the new discovery of genetic abnormalities that may predispose children to develop MDS and AML, this was originally described in the 70s with a germline mutation of RUNX1, which used to be called AML1, which is why it's there. There's been now 2 different genes that have been found to be familial causes of this disorder. And so this is rapidly expanding. Those are ETV6 and there's an ankyrin gene. The other 2 genes that I'll, again, briefly mention, I believe Dr. McLean talks about these, are GATA2 and CEBP alpha, are also newly discovered familial predispositions. You'll hear about that again later. Okay. So that's it for predispositions and constitutional. So for therapy-related AML, it's important to know that there are 2 characteristic chromosomal abnormalities and with different clinical characteristics in secondary AML. And this distinction is due to what is the exposure that caused the secondary or treatment-related AML. So I'd like to cover that. So the first exposure is either alkylating agents and or exposure to radiation. When these exposures cause myeloid malignancy as a therapy-related problem, there's typically a very long latency between the exposure and the onset of disease, and the genetic abnormalities in the leukemias are characteristically those that are listed here. These are typically high-risk MDS-related abnormalities like monosomy 7, 5q-, those sorts of things in complex cytogenetics. Distinguish that to MDS and AML arising from topoisomerase II inhibitor exposure, and that's mostly, in our practice, etoposide. Now remember, anthracyclines also have topo2 inhibitor activity, and so it's also not uncommon. Well, luckily it is uncommon, but among therapy-related AMLs in this category, anthracycline exposure may be the explanation, not uncommonly. Okay, so the cytogenetics in these cases are most commonly, like the vast majority, are MLL rearrangements, 11q23 rearrangements. However, it's important to recognize that other recurrent chromosomal abnormalities have been reported and as a group account for maybe 20% of therapy-related AMLs. Core binding factor leukemias, 1517, the Philadelphia chromosome, these have all been reported as secondary abnormalities to topo2 inhibitors. And so it's important to remember that that can also occur. Regardless of the age at presentation or why the therapy-related MDS AML happened, it tends to be more refractory to therapy than what we would normally consider de novo AML. And so these patients tend to require transplant for a chance at cure. Okay, so the second part of AML is epidemiology and risk assessment. So in epidemiology, they would like you to know the incidence of the major forms of leukemia and the peak age that they occur. I don't have to go through ALL again. You can see the peak age is early in childhood. AML is different. It has 2 peaks, and it's actually a real peak. In I believe it was 25% of the last COG AML study occurred in children under 25% of the cases were under 2 years of age. So there's a real peak in the young age group of AML in children between the ages of birth and 2 years. And then the incidence goes down, and then you begin to see an increase in incidence later in adolescence. CML has an extremely low incidence throughout childhood, begins to slowly increase as you get into adolescence. For both AML and CML, the peak age of that disease is obviously not on this graph, it's on this graph. It's in adulthood, right? So the longer you live, the more likely you are to get CML and AML. So stop getting old, because that wouldn't be good. So peak ages for myeloid malignancies are late. Peak ages for lymphoid malignancies, at least for leukemia, are relatively early. All right. So one thing that the test makers like to test about is the concordance rate of leukemias in monozygotic or identical twins. And so I want to go over this, even though it's not a public health problem, but it's a testing problem, if you will. All right. So the way I like to think about this is when twin A, if a baby or a child has an identical twin, the age at which the first twin is diagnosed with leukemia is what drives the concordance rates. It's really important to understand. So if the first child is less than a year old at diagnosis, the second child is going to get leukemia. And there's been one case that I know of reported in literature of discordance between two identical twins with leukemia, and that was because twin B got a viral infection, and the immune response to that actually eradicated the pre-leukemic clone, which is pretty cool. It's a plug for immunotherapy. But anyway, if the index case is less than a year old, there's a close to 100% concordance with a very short latency between the twins. And what this tells us is that there's a prenatal pre-leukemic event, like MLL rearrangement, for example, and that there's then intrauterine transfer of that pre-leukemic cell or leukemic cell between the twins. And so these are almost always, again, MLL rearranged leukemias, KMT2A rearranged leukemias. Now, if the index case is greater than a year, then the concordance rates drop significantly to only about 10 to 20%. And most of these, when there is concordance, have been shown to be clonal between the two twins. And the latency tends to be much longer between the two twins developing leukemia. And what this tells us is that, again, there was a prenatal pre-leukemic event, but it wasn't an oncogene quite as strong as MLL. It was either TEL-AML1 or AML1-ETO. Both of those have been linked to this. And there was intrauterine transfer, but that compared to the MLL rearrangement, there's a relatively low risk of the cooperating lesions that lead to full-blown leukemia developing in twin B compared to twin A. It's not guaranteed that twin B is going to develop the full-blown leukemia. And then finally, if the index case is older than 6 years old, there's very little increased risk, and there's very little concordance between that situation. And that suggests there's no prenatal leukemic event that's shared by the twins. Okay, so I hope that's helpful. I highly suspect you'll see a question or more than one that tests this. All right. Very important in AML is prognostic factors and risk stratification. And so there's a number of different content items that address this. And so it's very important to understand what these are. Before doing that, however, I want to make sure that we understand what the terminology that we're using. So prognostic factors and risk stratification are two different things. Risk stratification is prospectively using a prognostic factor to assign patients to a specific treatment. And so prognostic factors may or may not be used in risk stratification. Risk stratification is the use of prognostic factors to actually assign treatment. And so it's an important concept to understand. So what are some prognostic factors that are known to confer with outcome in AML but are not used in risk stratification? Most of these that are not used, it's because they're not independent of things that we do use, that these are just kind of co-phenomenon with things that we do use to risk stratify. So unlike in ALL, we don't typically use host characteristics like age, specifically to do risk stratification in AML. Race is also not used, even though it has been shown in a number of studies that African Americans and other non-Caucasian populations have inferior survival. Body mass index, so marked overweight and marked underweight have both been associated with poor outcomes, but we don't use that. And then pharmacogenomics are not currently used in risk stratification, even though those have been associated with outcomes. And then disease characteristics. Again, unlike ALL, we typically don't use white count at diagnosis as a risk stratification factor. And then finally, it used to be that morphology by the so-called FAB classification, which I'll talk about in a moment, used to be used in risk stratification. That's no longer the case. That's been supplanted now by genetic abnormalities, as I'll talk about in a moment. All right, so what is used? So there's been a fairly recent and major change in how we do risk stratification, so I wanted to cover how we did it before the change and how we're doing it now. And that is as follows. So up until fairly recently, there were favorable and unfavorable characteristics, and those patients were in two separate groups. And then there was a group of everything else, so-called intermediate risk AML. And most patients fell into that group of intermediate risk, which was really not very helpful because they're intermediate, it's most patients, we don't really know what differently to do with them. And so let's cover what the favorable and unfavorable have been and continue to be. So favorable features, Down syndrome related tends to be favorable, and those patients are treated on separate protocol. APL, the 1517 translocated that's treated with atra and arsenic, tends to be favorable, treated on separate protocols. The core binding factor leukemias, the inversion 16 and the 821, favorable and are treated separately, which I'll talk about in a moment. And then there's molecular abnormalities that are not evident on cytogenetics, nucleophosmin and CEBP alpha mutations that are favorable. The unfavorable, therapy-related AML and MDS-related AML are unfavorable. Certain cytogenetic abnormalities are unfavorable, like monosomy 7, 5q minus, abnormalities in 3q. There is one molecular feature, high allelic ratio FLT3 ITD mutations. That is an unfavorable feature. And then finally, poor response to therapy, being a primary induction failure patients. All right. Now, what has changed now is the incorporation of MRD into this risk stratification. So the intermediate risk patients, it's been demonstrated that their end of induction 1 MRD very nicely separates those patients into those with outcomes that are essentially identical to the traditional favorable patients and those whose outcomes are identical to the traditional unfavorable. And so that simplifies the risk stratification and makes it more useful in that now there's two groups. There's favorable and unfavorable, with the intermediate risk group now separating into those two based on MRD. Okay. A point to make is in the next upcoming major COG study, there's been a couple of refinements to this in that, and I'll just mention one. Again, this is not going to be tested, but important for you to know this is constantly being refined. So the MLL rearrangements, the 11q23 abnormalities, those have traditionally been considered intermediate risk. It turns out that most of them continue to be intermediate risk, but there are certain fusion partners that really separate out and are either favorable or unfavorable. And so I'm not going to go into those details, but that's one of the refinements that continues to be made over time. And you should get ready for the test, but then you should be thinking there's probably some updates to what's in here, and you should follow the literature for that, of course. Okay, how do we diagnose AML? Well, so there's a classification, and I've been talking about FAB, and I'm going to talk about that now, and then relate it to the newer classification, which is the so-called WHO classification that I mentioned at the very beginning. And then also, it's important to know the characteristic clinical presentations of some of the subtypes of AML, and so we'll discuss that in this next section. I would think this is another important slide for you to highlight and to think about when you're studying. So I'm not going to go through all the details, but in the column on the left is the M0 through M7 designation. This is the old FAB classification that began to be used in the 70s, and you'll keep hearing us old-timers talk in terms of M3, M7, M2. It's no longer the technical way to classify AML, but you're going to hear it in your clinical practice. What I've done here is take each of those and then on the right, comment on what are the features that have been traditionally associated with each of these morphologic classes. And so I've highlighted there the big four in red. So those are the four cytogenetic abnormalities with the FAB classification that they're highlighted. And then highlighted in yellow the clinical features. So chloromas for M2, DIC and bleeding for M3, the tendency for the M5 or monocytic leukemias to infiltrate skin, gums, CNS, et cetera. And then M7, that's the platelet or the megakaryocytic form of AML. There's a tendency for fibrosis to develop in the bone marrow and the liver in those leukemias. So those are just a few of the highlights from this table. Again, I'm not going to go through it in detail, but this is what's used to be the classification. The other thing to mention at the very top is that it used to require 30% blasts in the bone marrow to diagnose AML, regardless of any of these other features. So what's new? Well, what's new is the WHO classification, and this was initially published in 2008, recently updated. So what's important to know here is that there is no minimum percentage of blasts if you have a AML-defining genetic abnormality. All right? If you don't have an AML-defining then there is a minimum, and it's now 20%. Okay? So that's an important change. I like to think about classifying AML by asking 4 questions of every case. 1, is the AML due to prior therapy? If so, you diagnose it as therapy-related AML, and you move on. If not, you ask the second question, is the AML in a child with Down syndrome? If yes, it's Down syndrome-related AML, and you move on. If no, you ask the next question. Is one of the major Big 4 recurring abnormalities present? If yes, then that's the diagnosis. AML with a KMT2A rearrangement or MLL rearrangement. AML with a 15-17 translocation, okay? And then finally, if the answer to all of those is no, is there dysplasia, prior MDS and or an MDS-related mutation, then it's AML with myelodysplastic related changes. Most cases, well, many cases, if not most, at least half, will be no to all. And that's where the WHO refers back to FAB. So it's important to know the FAB because if none of these other things is true, then it's going to be AML diagnosed based on the old morphologic classification. I hope that makes sense. That's how we classify AML and how your pathologists do it now. Okay, so immunophenotype. Flow cytometry is the gold standard for diagnosing a new acute leukemic, and the test makers love to know if you know what CD markers are on the different subsets of leukemia. So let's talk about it. Here's a table. I'm going to highlight in yellow or in different colors the important patterns of expression that are routinely tested, okay, as I go through these. And this will be in your syllabus for you to refer back to. First thing, there are pan-myeloid markers. The most important of those are CD13, CD33, and myeloperoxidase. Note that M7 is the one subset of AML that typically does not express myeloperoxidase, but expresses other things which we'll talk about. All right, so those are highlighted in yellow. Okay, the next arrow that comes up is monocytic. So these are the M4 and M5 markers, and the major ones to know are 11B and 14, and those are highlighted in blue in the table. The next, erythroid markers. These are markers that would be expressed in the M6 or the erythroid leukemias, and the most important one to know there is glycophorin A, also known as CD235A. And then the next is the megakaryocytic, which is the old FAB M7, and these are the markers that are most characteristics of that, 41A, 42, 61, and absent myeloperoxidase, as I mentioned at the beginning. APL, this is the 15-17 promyelocytic leukemia. It has a very characteristic flow pattern, which is that the cells autofluoresce. They glow even without an antibody attached to them, which I think is really cool. And so they're higher on the flow cytometer, on the dot plots, than other cells, which is really kind of a neat thing. They have very bright CD33. They are HLA-DR negative, which is not typical of AML, and they are CD34 negative characteristically. Okay, what was the last one? Oh, yeah. The other thing I want to mention is the 821 cases. This is the old AML1 ETO, now it's a RUNX1 translocation, one of the core binding factor. These often aberrantly express CD19 at pretty high levels. And so if you see an AML case that otherwise has pretty standard AML expression, but your flow cytometrist or your hemopath says there's a lot of CD19 expression, you can suspect, and it often will end up being an 821 translocation. Obviously, you got to wait, but it's often kind of an early hit, and you can impress your friends at dinner by saying, I predicted that based on the CD19 expression. All right, there are leukemias that don't neatly fit into AML or ALL. You're aware of this. These are leukemias of ambiguous lineage. There's two major types in the WHO classification. One is a completely undifferentiated leukemia, which basically expresses very little that tells you it's even hematopoietic. Those are rare, but they happen. And then there's the more common mixed phenotype acute leukemia, where either there's a single population of cells that has both lymphoid and myeloid markers on it, or there are two populations of cells, one of which is more lymphoid, one of which is more myeloid. Both happen, and both are covered by the umbrella of mixed phenotype acute leukemia. These are often MLL or KMT2A rearranged. That's why MLL was called MLL, stands for mixed lineage leukemia, and so it makes sense that these would be associated. The most common mixes are T and myeloid, followed by B and myeloid. And then the other thing to mention about these leukemias, so there's been some recent data showing that the way to approach these leukemias, it may be best to start with ALL therapy, even if the predominant population is myeloid, because the toxicity of ALL induction is less, and the responses to ALL induction, even if the predominant population is myeloid, seem to be just as good. And then adjust your therapy based on what you see with residual disease. The other thing is that it does appear that these leukemias, to give them the best chance of cure, do really require bone marrow transplant in first remission. I think that's fair to say that's a typical approach. Okay, treating AML. That was just a little preview by talking about treating MPAL, but let's talk about the actual treatment of ALL. So lots of points in the old content outline, specific content points about treatment of ALL. I won't go through them individually. Suffice to say, it's important to know how to treat AML if you're going to be a board-certified pediatric hematologist oncologist. All right, so how do we do it? I'm going to try to keep it simple because there's some minor differences between the way different groups treat AML, but there's major themes across them. The first is that remission induction typically consists of 1 to 2 courses of very intensive chemotherapy that is built on 2 different drugs, an anthracycline and cytarabine. Those 2 drugs, either one of the anthracyclines and cytarabine, are absolutely required for inducing remission in AML in a standard setting. Etoposide is added in the most recent COG and other international groups as well, but the 2 drugs that are most important to have are Ara-C and an anthracycline. There is a high risk of invasive infection with this induction regimen, as you know, and the CR rates are much lower than they are in ALL. They tend to be somewhere in the 75 to 80% after induction. One thing that's interesting to note is that the recently completed COG protocol, after the first block of kind of standard Ara-C, daunorubicin, and etoposide, would switch to mitoxantrone and high-dose Ara-C if the patient was high risk. That's something that may or may not continue, but you may see reference to that in a question. Okay, post-remission consolidation, very different in AML than ALL. Bone marrow transplant is used in first remission much, much more commonly in AML than in ALL. And so the typical approach is for all high-risk patients to be offered bone marrow transplant in first remission. Remember, that's the traditional high-risk patients based on genetic abnormalities plus the MRD positive intermediate risk patients. And so that's typically with the best donor. And then no low risk patients typically are offered transplant in first remission, even if there is a matched SIB. That's a difference in practice over time. And so that's the most typical approach to using transplant in AML. For patients who don't go to transplant, they do receive additional intensification courses. The number of courses that patients receive has been anywhere from 3 to 5 in different clinical trials, most commonly 4, I would say, the 2 induction plus 2 post-induction courses. That I don't think is all that important to know. This, again, would be in any high-risk patient that doesn't have a donor available or can't go to transplant, and all low-risk patients. Usually these are focused on high-dose Ara-C. The Ara-C that's used in induction tends to be low-dose frequent dosing over 10 days or 7 days. There's the classic 7 and 3 regimen, which is 7 days of Ara-C. We use 10 in the COG. In the post-induction course, it's typically high-dose Ara-C given given over briefer periods, so-called Capezi use of Ara-C. Okay. All right, what about CNS prophylaxis in AML? In general, it's much less intensive than what's used in ALL due to low rates of CNS relapse with standard therapy. For patients that are CNS positive at diagnosis, they typically will get frequent intrathecal treatments until their CSF clears, and then once per course beyond that. Cranial radiation is almost never used in AML, except in patients with the rare patient with CNS relapse. And most of those tend to occur in monocytic cases, and most of those are MLL rearranged or KMT2A rearranged. Maintenance therapy, like a long-term extended maintenance, it's been tried in AML and it doesn't work. There were randomized studies back in the 70s and 80s that demonstrated that long-term, low-intensity maintenance therapy doesn't improve cure rates, just causes toxicity. So with AML, you either cure it within the first 6 to 8 months or you don't. Maintenance isn't going to help. Okay. Supportive care is extremely important in AML because our therapies, at least as they are now, are extremely toxic. So I'm going to highlight some things that are not only important for you clinically, but also this is pretty easy to test on, and I think it's important to understand. So admitting patients during periods of neutropenia is highly recommended in AML due to the significant risk of life-threatening infections, and in particular, bacterial sepsis. Is quite common, rates of up to 23-30% during these courses. Most of these infections are due to either strep viridans, which is why some degree of gram-positive prophylaxis and certainly very early use of vancomycin and empiric treatment is important, and then the gram-negative enterics. And so it's obviously very important to keep good gram-negative coverage on as well. Aggressive empiric treatment, as I've mentioned. Bacterial prophylaxis itself is controversial and is not considered standard due to some concerns regarding antibiotic resistance and so forth. But at your own center, I'm sure are having those discussions. It's not something I think is going to be tested upon because there is controversy regarding the value. And then finally, fungal and pneumocystis prophylaxis are commonly used. Growth factors are not commonly used due to concerns, especially in myeloid leukemias, of the G-CSF actually promoting leukemia. Some leukemias do have functional G-CSF receptors on them. But again, there are regimens like the FLAG regimen, for example, that contain G-CSF, and those are quite effective. So I think this is a little bit controversial, but certainly growth factors should not be considered routine in AML. All right, let's switch gears to treating APL. So we've already mentioned a couple of clinical aspects. There's a high risk of life-threatening bleeding with up to 10% mortality in the first few weeks of diagnosis. And I can tell you that this is true. We just had a very unfortunate case of a child come in with APL who died of a massive pulmonary and CNS bleed. So these patients, when they come in, you need to look at a smear quick and try to decide. I tell you, the truth is, when I'm on service and a new leukemic comes in, first thought in my mind is it APL or not before anything else? Because what I don't want to do is miss an APL, an opportunity to get ATRA started, start throwing blood products at them, because you can really change the natural history of that bleeding. And so this is the real deal. So when these patients come in, you're closely monitoring their coagulation factors, you replete what you can, you start ATRA as soon as possible. It is never wrong to start ATRA if you partly suspect APL. If you look at a smear and it looks like it could be APL, start ATRA. It's vitamin A. It's not going to make them ineligible for anything. It's not going to hurt them. So always err on the side of caution, because that is probably the one thing, other than very active blood product management, that you can do to change the natural history of the bleeding risk. Other interventions like heparin, Amicar are not standard and are quite controversial. It's basically replete what you can in terms of FFP, platelets, cryo, precipitate, and get ATRA started. Okay, differentiation syndrome. Even before you start ATRA, this can occur, but after ATRA, it is much more common, and it also occurs with arsenic. Anything that's effective against APL can induce differentiation syndrome. And what happens is, as the cells differentiate from promyelocyte through that cascade to neutrophils, and die, they begin to release the granules, and that can cause this differentiation syndrome. Characterized by fever, edema, pulmonary infiltrates, and respiratory distress. The risk correlates with high white blood cell counts at diagnosis, and in those cases in particular, it can occur spontaneously even without ATRA. It's important to promptly recognize that it's going on and to start steroids. And you hold ATRA until it begins to resolve, and then you can restart. The third thing is arsenic. So it's increasingly being incorporated into consolidation for APL to reduce anthracycline exposure. And this is really exciting, for patients that have low-risk APL, defined as an initial white count of less than 10,000, the current standard management is just to treat with ATRA and arsenic with no chemotherapy, ever. And that can cure up to 90% of patients, which is absolutely amazing. So we've gone from APL 20, 25 years ago being one of the hardest AML to treat, requiring the highest cumulative doses of anthracyclines with very poor outcomes, to, in the era of ATRA and arsenic, no chemotherapy for the majority of patients. It's really quite remarkable. Hence the exclamation point at the end of the slide. All right. So again, not going to go into detail because Dr. McLean will, but I think it's important to know the relationship between MDS and AML because they test on it. So in children, unlike adults, the vast majority of our AMLs are so-called de novo, meaning they're not preceded by a known MDS phase, okay? MDS in children commonly arises in the setting of underlying constitutional disorders. If you have a true MDS arising in a child, you need to exhaustively look for something in the germline that caused that, because that's weird. And then MDS in children does have similar prognostic and therapeutic implications as in adults. Similar, not identical. Eventual progression AML is the general rule, although there have been exceptions. Generally, MDS cases do require transplant for cure, and there is a questionable role for pre-transplant chemotherapy. There's an increasing use of demethylating agents like azacitidine and decitabine in this setting. Again, Dr. McLean will go through that in more detail. All right. Test makers love to ask about hyperleukocytosis, and it's important. This is an important clinical problem, particularly in AML, much less of a problem in ALL. All right, so it's important to know what the complications are and how to manage it. So the risk factors for hyperleukocytosis are, not surprisingly, a high white count, and this is especially true in AML. So we've had cases of AML with white counts as low as 50 or 60,000 that have had significant clinical symptoms of hyperleukocytosis. So the white count threshold for getting into trouble with leukocytosis is much, much lower in myeloid leukemias. The cells are bigger, they're stickier, they have a greater impact on the viscosity of the blood, which is the ultimate problem here. And so what happens is the blood gets viscous, it sludges in the capillary beds in various organs. The main organs that are involved are the brain, the lungs, and the kidneys, and the clinical manifestations are as expected there. How do you treat? You treat the leukemia as soon as you possibly can. You get chemotherapy started ASAP. You can do exchange transfusions or pheresis. Usually, getting chemotherapy started will be the most effective and easiest way to deal with this problem. However, if you have the ability to get pheresis done quickly or do a manual exchange transfusion, by all means, that can help also. Okay, late effects in AML. So if the patient has received chemotherapy only, the major late effects are driven by the chemotherapy that they received, like anthracyclines. We know that cumulative exposure of around 450 mg per meter squared of doxorubicin equivalents is associated with an increased risk of cardiotoxicity, and many patients will get that. Etoposide, as I've mentioned, is associated with therapy-related MDS AML. Typically, it's the one that results in short latency and MLL or KMT2A rearrangements. And then high-dose Ara-C can cause long-term neurotoxicity. All right, after transplant, all of the above plus the transplant risks, which I won't go into. All right, indications for radiation in AML are very few and far between. Generally, it's limited to treatment of life-threatening complications, like, for example, chloromas of the spinal cord. Sometimes you can do urgent radiation. TBI is typically not a component of prep regimens for AML, and cranial RT is generally not used. So radiation is not typically used for AML. All right, so cool. That was AML. let's talk about CML. This is a briefer topic, but it is not something that you won't be tested on, I'll tell you that right now. This is an easy thing to test because there's a lot of cool pearls in here, and so I think it's important to cover what those are. All right, so the basic science and pathophysiology. Lots of the old content guideline specifications wanted you to know about what is the molecular basis of CML and the cool things about treating it with targeted therapies. So let's talk about that. How do we define CML? It is one of the myeloproliferative neoplasms. The remainder, Dr. McLean will talk about. It originates from an abnormal pluripotent stem cell in the bone marrow. It is characterized and defined by the Philadelphia chromosome, which is a translocation of 922, and that fuses the BCR and the ABL1 genes together. It has a triphasic natural history. It often starts and is diagnosed in the chronic phase, and if left to its devices, it will accelerate through an accelerated phase and then finally to a full-blown blast crisis, which is indistinguishable from acute leukemia. Luckily, we don't just watch that natural history anymore. We treat it. So some patients will present in the accelerated phase and in blast crisis without a known chronic phase preceding it. So that's important to recognize as well. All right, so the molecular biology, I hope, this is a review. BCR and ABL are fused. ABL is a kinase. When the ABL kinase gets aberrantly fused to the BCR gene, it makes the kinase unregulated. It no longer responds to its ligand and goes on and off. It's just on all the time, and that drives downstream signaling. All right, so the way that downstream signaling works is through phosphorylation, and it requires ATP to bind to the kinase and then give its phospho group and then come off as ADP. The way Gleevec, imatinib, and all the other TKIs work is they sit in that ATP binding pocket and prevent ATP from binding, and that turns off the downstream signaling. Patients get better. Okay, so how do we diagnose CML? Most patients, as I mentioned, are diagnosed in the chronic phase. Up to 40% of patients are asymptomatic and are detected simply because someone did a CBC for some unrelated reason. This is absolutely true in my clinical practice. It's pretty remarkable. And so what do you see on that CBC, which makes you suspicious of CML? High white count, usually with a left shift. They may or may not be anemic. They may or may not have high platelets. They rarely have low platelets. And you will sometimes, often, if you look hard enough, see basophilia with or without eosinophilia in the blood. When patients do present with symptoms, they are as follows, in this order of frequency: abdominal pain, dysphagia, difficulty swallowing, increased abdominal girth. All three of these are from the fact that most CML patients will have massive splenomegaly at the time of diagnosis. They will also be fatigued. They can have weight loss, night sweats, rarely bleeding. Now, here it's interesting. The bleeding from CML is in the setting usually of very, very high platelet counts, and that's from something called acquired von Willebrand's disease. So when you have very, very high platelet counts, that essentially is a sink for von Willebrand's factor, and you get a secondary coagulopathy from that. So don't be reassured by a high platelet count. Those patients can actually be the ones that are most likely to bleed. Okay, leukostasis is actually relatively rare in CML, despite very high white counts. Priapism. Okay, for years I made fun of this. For some reason, the ABP content outline had a real fixation with priapism in CML. And so for my entire career, I had never seen a case of CML present with priapism. Last year, had a CML case present with priapism. So I stand corrected. It does happen. I don't know why. It ended up on tests over and over and over again. Now, if I was to write a test question for CML, I might put priapism in there. I don't know. So at any rate. All right, where was I? Natural history. The progression is it happens. The variable latency occurs. Now, for blast crisis, 2/3 of them present with myeloid acute leukemia and 1/3 with ALL. This is an important point. If you have a new case of ALL that is pH positive, sometimes it's really hard to distinguish that from being a de novo pH positive ALL from being a presentation in blast crisis, of lymphoid blast crisis of CML. The transcript, whether it's P210 or P190, can be important, which I'll talk about in a moment. P190 is more common in ALL, P210 more common in CML, and or ALL and CML. What is actually really helpful is if the patient goes into remission, if you send their remission blood and marrow for FISH, for pH positive, and it remains positive even though the patient's in remission, then that's CML in blast crisis and not de novo ALL. It's a cool little trick. Okay. So this is what I was talking about at transcripts. So the smaller transcript of BCR-ABL is called P190, and that's most typical in ALL. The larger transcript called P210 is most common in CML. Diagnosing CML, you can probably get away in most cases with just sending the blood and getting the BCR-ABL, but it is recommended to do a bone marrow because the bone marrow may be in a different phase. You may find increased blasts in the bone marrow and not in the blood, and cytogenetics on the bone marrow can be helpful in that there can be additional cytogenetic abnormalities other than the Philadelphia chromosome that may correlate with eventual outcome. Okay, how do we manage and treat? Last section. All right, so we should know the principles of targeted therapy, such as imatinib, plan the treatment of a blast crisis, know the indications for and timing of transplant, know the therapeutic options. Transplant, transplant, transplant. So these content guidelines were written in a prior era, and I'm going to talk about how the newer era, our focus is a little bit different in this disease. So before imatinib and other TKIs were developed for CML, the only curative long-term therapy was transplant. So essentially, all children received transplant with the best available donor. Hydroxyurea and interferon were what were used primarily to control disease prior to transplant. Everything changed with the introduction of tyrosine kinase inhibitors. What we now do is start a TKI and continue maybe indefinitely. All right, so you're probably aware of STOP studies. So probably the biggest unanswered question in CML is there a subset of patients, adults and pediatrics, where you can safely stop a TKI? And it appears, the bottom line from those studies so far, it appears that in patients who get into a very deep molecular remission with tyrosine kinase inhibitors and remain there for years, if you stop, half of them will never have recurrence of disease, half will, and if they do, you haven't harmed them by waiting for their disease to come back to restart TKI. That's just the bottom, that's a bottom line, my bottom line interpretation of the data so far. Okay, now we consider transplant in chronic phase only for patients with matched family donors, and I'll tell you that is quickly becoming less common as well. So even if we have a CML patient who's responding well to TKIs, even if they have a matched SIB waiting for them, we'll talk about it as an option and discuss it with the family, but it's not something that we would typically recommend. All right, you definitely need transplant for recurrent or refractory chronic phase. Perhaps, if you can try a higher dose TKI and or one of the newer generation TKIs, that may do it, but for patients that have generally been not responsive to one or more TKIs, I think transplant is still the answer. Patients who present with accelerated phase or blast crisis, once you get them into chronic phase, those patients very clearly need to go to transplant because that is going to relapse and cause death without a transplant. Okay, so the kinase inhibitors. I'm not going to go into details here. You know about imatinib, dasatinib, nilotinib. All of these are now FDA approved and available. Ponatinib, not yet FDA approved for children. This is the only one that has been shown to be active. The main one that's been shown to be active against the T315I resistance mutation of the ABL kinase. Okay, I'll tell you that our current practice is to actually start with dasatinib or nilotinib. The data are that it more quickly induces that very deep molecular remission. There are not strong data to correlate that with long-term outcomes, and many people are still using imatinib at the start, and that's perfectly acceptable, but that's our current practice. Transplant, I've mentioned, remains controversial. I've listed there the things that I've talked about on the prior slide. All right. Response, 3 principal ways to assess response in CML. Hematologic response means that the blood gets better and the splenomegaly goes away. Cytogenetic response means that you can't detect the BCR-ABL with non-sensitive techniques like karyotype and FISH. Molecular response means that you can't or can detect at extremely low levels the transcript using techniques like PCR and next-generation sequencing. All right, so the most recent guidelines have us doing bone marrow aspirates for response, never, which is good, and to do every Q3-month testing until you reach a major molecular response, then every 3 to 6 months thereafter. You don't have to memorize what is a suboptimal or a failure of response because it's on this table. At various time points, we have defined what is a suboptimal pace of response and what is a frank failure, and this is what would indicate a change to a different tyrosine kinase inhibitor and or proceeding towards bone marrow transplant. And then finally, I think that, yep, this is it. The response to the TKI treatment is by far the most important prognostic factor in CML. If your patient is responding to tyrosine kinase inhibitors, that's great. If your patient is not, then that is a poor prognostic factor, and that's a patient you start to worry about. So the patients that have a rapid and sustained response to TKI have an absolutely excellent outcome. I think that many of those patients may eventually even be able to get off their TKI. TKI resistance, however, does occur. Primary resistance is defined as treatment failure or suboptimal response with the initial TKI. Secondary resistance is more common, where you see response but then loss of response, and that's typically due to development of these resistance mutations. Both primary and secondary can be caused by these mutations, but most commonly secondary. And the one that you worry the most about is T315I because it's the most resistant to the large panoply of tyrosine kinase inhibitors, but ponatinib can be effective there. And then finally, it's the TKI-resistant patients that generally require transplant for cure. So those are my prepared comments. I hope that prepares you reasonably well for the test, and happy to take any questions if we have time.